Hello everybody, my name is Riley. In this presentation I will critically analyze and review the use of non-invasive brain stimulation techniques, or specifically transcranial magnetic stimulation, or rather TMS. The focus of the presentation will be on the application of TMS in major depressive disorder. I'll explore the physiological basis of both the disorder and TMS, review the literature on the efficacy of the treatment, evaluate the process of TMS, and call attention to the gaps in knowledge as well as direction for further research. Within recent decades, non-invasive brain stimulation techniques have garnered significant attention as possible intervention methods for psychological conditions. These techniques aim to alter brain activity without penetrating the skull, very much different to other proposed interventions such as pharmacological and invasive neurosurgical approaches. Among other non-invasive brain stimulation techniques, TMS remains the most widely researched and is actually practiced in clinical settings in several countries for treatment of depression. Approximately 16% of people suffer from major depressive disorder sometime during life. Neurobiologically, depression can be associated with abnormalities in the prefrontal limbic circuitry. Specifically, hypoactivity of the left dorsolateral prefrontal cortex and hyperactivity in the limbic regions, particularly the amygdala, are often observed. The abnormalities and alterations are typically thought of as disrupting top-down regulation of cognitive and emotional processes. Diving into the neurochemical specifics, unregulated monoaminergic neurotransmitters such as dopamine, serotonin, and norepinephrine have been implicated. However, more recent research has provided models emphasizing synaptic plasticity and modified connectivity across neural networks. Exploring the physiological effects of TMS, TMS operates on the principle of electromagnetic induction. A coil placed over the head generates rapid electromagnetic pulses that induce activity and currents in neurons present in the cortex. TMS can control its effect, increasing or decreasing cortical excitability depending on the frequency of pulses and pattern. 10 Hz is a level which will excite, lower frequencies will inhibit, so around 1 Hz. With major depressive disorder in mind, higher frequencies will generally be applied to the left dorsolateral prefrontal cortex. This will modulate and enhance hypoactive functioning. Studies have also investigated applying lower frequencies to the right dorsolateral prefrontal cortex to inhibit overactivity. The efficacy of TMS treatment in depression in clinical settings has been investigated in numerous controlled and randomized trials. A study done by George and Post 2011 showed that consistent high-frequency TMS of the left dorsolateral prefrontal cortex significantly reduced symptoms of major depressive disorder, even in patients with treatment-resistant depression. Further meta-analysis by Berlim, van der Eind, and Daskalakis in 2013 further confirmed a positive effect compared against sham stimulation. More recent studies, such as one by Lefauture et al. 2020, found TMS to be largely applicable as a first-line intervention if applied in cases where one course of antidepressant medication fails to alleviate symptoms. Unfortunately, TMS has a very varying effect size across studies. Remission rates range from approximately 25 to 40, and here you can see on this graph they're slightly different there as well. While TMS is clinically significant, it's just out of range of universal efficacy. Despite the positive outcomes of TMS, its literature is limited in many ways. To start, there is a large heterogeneity in parameters for stimulation, including frequency, orientation of the coil, and total treatment sessions. This heterogeneity makes cross-comparison across studies difficult. Furthermore, sham stimulation faces a methodological challenge of its effect occasionally being distinguishable due to sensations produced while under stimulation. Long-lasting effects and their durability is currently a concern. Initial response rate is high, but so is relapse within 6 to 12 months post-treatment. And lastly, most evidence is collected from within high-income countries. Of course, this raises questions about generalizability across all healthcare contexts. Mechanisms of change have been proposed to explain the antidepressant effects of TMS. Increasing the excitability within the left dorsolateral prefrontal cortex, TMS restores balance between limbic and prefrontal regions. This, of course, means that top-down regulation of emotional and cognitive processes are enhanced. Studies applying neuroimaging support claims of increased connectivity between the dorsolateral prefrontal cortex and the anterior cingulate cortex after treatment. On a cellular level, frequent stimulation appears to have long-term potentiation-like effects. Animal studies have been conducted and produced results that suggest alteration of the monoaminergic systems, boasting increased dopamine release within the striatum after stimulation. However, despite the plausibility of these mechanisms, it is still debated whether the changes in cortical excitability are the primary driving force of improvements, or whether a broader network level reorganization plays a larger role. Utilizing the physiological mechanisms of TMS to counteract the physiological mechanisms of major depressive disorder becomes clear when an understanding of these mechanisms is achieved. Stimulating an underactive prefrontal cortex aligns with the recorded neural deficits found in depression. The effectiveness and strength within this alignment is moderated by several issues though. One example is the fact that not all people with major depressive disorder experience hypoactivity in the dorsolateral prefrontal cortex. However, this could explain some of the variable rates in TMS effectiveness. TMS relies on the theory that cortical excitability causes symptom improvement. However, the evidence supporting the direct causal link between them is limited. Numerous studies have also observed changes and activation of distant areas of the brain, suggesting that additional unidentified mechanisms may be involved. Therefore, while the theoretical use of TMS as a direct intervention is compelling, the evidence of TMS suggests its use as a cautious corrective rather than a definitive intervention method. Further research needs to prioritize specific areas first. Efforts should be directed at identifying biomarkers, which are individual markers in the body, allowing the prediction of how individuals will respond to TMS, as well as how to tailor protocol toward the individual. Further studies into the durability of TMS effects and further research into maintaining treatment should be considered. TMS has yet to be combined with various methods of psychotherapy and pharmacological means, as these may yield synergistic effects. Lastly, of course, more information is required and further researched, or it must be further researched and undertaken with underrepresented populations, such as low-income populations, and across differing clinical settings to ensure access to these treatments remains equitable. To conclude, transcranial magnetic stimulation, or TMS, stands as an important advancement in non-invasive stimulation for patients undergoing major depressive disorder. The technique is grounded with a plausible neurobiological rationale and is supported by much evidence to demonstrate a moderate level of efficacy. Despite this, the variables in outcomes and lack of understanding of all potential mechanisms within TMS means the technique requires further evaluation. Overall, TMS is a valuable tool that has potential to significantly increase treatment outcomes for people suffering depression. And lastly, here are my references. Thank you all for listening. Have a wonderful rest of your day.